The emergency room doors exploded open at Walter Reed Medical Center at 0300 hours. What stumbled through those doors would change everything I thought I knew about modern medicine. I'm Sergeant Marcus Webb, and I was bleeding out from a firefight in Mosul. 3 bullets, collapsed lung, maybe 20 minutes before I coded. But when the trauma team surrounded my gurney, I pushed them all away. "Get me the old nurse," I managed to say through the blood in my mouth. "The one they make fun of, Clara." The attending physician looked at me like I'd lost my mind. Maybe I had. But I'd seen what Clara Patterson could do with nothing but her hands, some basic supplies, and 40 years of experience that everyone called outdated. They thought her methods belonged in a museum. They were about to learn why some techniques survive for a reason. Clara Patterson had been a nurse for 42 years. At 65, she should have retired, but Walter Reed kept her on because, well, officially, because of her institutional knowledge. Unofficially, because firing her would look bad. The younger nurses called her Grandma Gauze behind her back. The residents made jokes about her refusing to use the latest equipment. During staff meetings, whenever Clara suggested a hands-on assessment technique, eyes would roll. "We have monitors for that, Clara," Dr. Jennifer Hartman said at last week's team briefing. "We don't need to manually check pulses when we have continuous monitoring." Clara just nodded. She'd learned years ago that arguing with people who thought technology solved everything was pointless. She kept doing things her way quietly on her shifts. She carried a small leather pouch in her scrub pocket. Inside, a traditional stethoscope, not the electronic kind, a pen light, a small notepad, basic wound care supplies, and a pocket watch her father had given her when she graduated nursing school in 1983. "Outdated," the other nurses whispered. "Primitive. Somebody needs to tell her this isn't the 1980s anymore." But Clara had seen things. 30 years in combat support hospitals, deployments to Iraq, Afghanistan, Somalia. Places where the power went out, where the fancy equipment failed, where all you had was your training, your hands, and your brain. She knew how to read a patient's body, how to spot internal bleeding by skin temperature changes, how to assess shock progression without a blood pressure cuff, how to keep someone alive with basic supplies when everything else failed. And the young nurses didn't know this. They'd been trained on simulators and computer systems. They were brilliant with technology, but they'd never had to save a life with just gauze, tape, and knowledge. The breaking point came 3 weeks before Marcus arrived. A software update crashed the electronic health record system. The entire ER went dark digitally. No access to patient histories, no medication lists, no allergy information. The younger staff panicked. Dr. Hartman called IT support, her voice sharp with frustration. "How long until it's back up?" "Could be hours," came the response. "We have incoming trauma patients." Clara walked over quietly. "I have paper charts. I've been maintaining backup records." Dr. Hartman stared at her. "Paper charts? Are you serious?" "Yes. Every patient from the past 6 months. Full histories. Medications, allergies, treatment notes." That's against protocol. Everything is supposed to be digital now." Clara met her eyes. "Protocol doesn't help much when the system crashes. My paper files do." They used Clara's charts. Every single one was complete, organized, detailed. The ER continued functioning. Lives were saved. Did anyone thank Clara? No. In fact, at the next staff meeting, Dr. Hartman gave a presentation about the importance of following proper digital documentation protocols. The message was clear. Clara's methods were tolerated but not valued. Nurse Taylor Morrison, fresh out of nursing school, confronted Clara in the break room that day. "You know you could get in trouble for maintaining unauthorized records, right?" Clara poured her coffee.
I could.
Why, but I won't let a patient die because someone decided paper is old-fashioned. That's such a boomer mentality, Taylor said. Technology exists for a reason. So does knowledge, Clara replied. Technology is a tool, but if you don't understand the fundamentals, the tool becomes a crutch. Taylor laughed. Okay, Grandma Gauze, whatever you say. Clara didn't respond. She'd heard it all before. Sergeant Marcus Webb wasn't supposed to be in an ER at Walter Reed. He was supposed to be dead. The mission had gone bad in Mosul. Bad intelligence, wrong building, ambush. His Delta Force team walked into a kill box. Marcus took 3 rounds, one through his left shoulder, one that grazed his rib cage and collapsed his lung, and one that lodged in his abdomen, dangerously close to his liver. His team extracted him under fire. A combat medic Rodriguez kept him alive during the helicopter ride to the military hospital in Iraq. From there, an emergency medevac to Ramstein Air Base in Germany. Then the long flight to Walter Reed. 28 hours from taking fire to hitting that ER. 28 hours of bleeding, pain and survival. But here's the thing about Marcus. This wasn't his first time getting shot, and it wasn't his first time seeing Clara Patterson work. 4 years earlier, Marcus had been on a protection detail in Kandahar. A convoy hit an IED mass casualties. The field hospital was overwhelmed, equipment failing in the desert heat, supplies running low. Clara was there as part of a nursing support deployment. Marcus watched her save 3 soldiers that day with nothing but basic field supplies and hands-on techniques. No fancy monitors. In no advanced equipment, just skill, experience, and an understanding of the human body that you couldn't learn from textbooks. One soldier, Private Chen, had internal bleeding. The ultrasound machine was down. Clara assessed him manually. Pulse points, skin temperature, abdomen palpation, breathing patterns. She identified the bleed location accurately enough for the surgeon to go straight in and stop it. 15 minutes from assessment to operating table. Chen lived. Marcus never forgot it. He made a mental note. If he ever got hit bad, he wanted Clara Patterson. And now, bleeding out on a gurney at Walter Reed, he remembered. The trauma bay exploded with activity when Marcus rolled in. Multiple GSWs, BP dropping, tension pneumothorax on the left. Dr. Hartman took command. I need 2 large-bore IVs, type and cross for 6 units.
Get me a chest tube tray. Someone page surgery. Nurse Taylor Morrison moved efficiently, prepping equipment. The trauma team surrounded Marcus, all hands and controlled urgency. Marcus's eyes were half open, his breathing labored. He'd lost a lot of blood, but he was conscious enough to see what was happening around him. State-of-the-art monitoring equipment, digital displays everywhere. The newest trauma technology money could buy. All very impressive, all useless if they didn't understand what they were looking at. Heart rate 140, BP 80/50 and falling, Taylor called out, reading the monitors. Dr. Hartman examined the wounds. We need to get him to OR now. Possible liver lack. The shoulder wound is through and through, but that chest... No, Marcus said. His voice was weak, but clear. Everyone stopped. Sir, you need immediate surgery, Dr. Hartman said. Get me Clara Patterson. Dr. Hartman blinked. Who? Clara. The nurse, old one. Taylor Morrison actually laughed. Sir, you're in shock. We have the best trauma team. Get Clara? Marcus coughed, blood flecking his lips. Now! Dr. Hartman looked frustrated. Sir, I don't know who. I do, said a voice from the doorway. It was Dr. Robert Chen, the same Chen that Clara had saved in Kandahar. He'd become a surgeon. He worked at Walter Reed now. He's asking for Clara Patterson, Dr. Chen said. She's on shift tonight, 3rd floor post-op. You can't be serious, Dr. Hartman said. We need to get him to surgery, not bring in some... Pager, Marcus said, his eyes locked on Dr. Hartman. I'm refusing treatment until Clara assesses me. That's insane. That's my right. Marcus's voice got stronger. Patient. Choice. You taught me that at training. Dr. Chen stepped forward. He's right. Patient can refuse treatment, and if he's requesting a specific nurse for initial assessment before consenting to surgery, they paged Clara. She arrived 4 minutes later, still carrying a blanket she'd been bringing to a post-op patient. When she walked into the trauma bay, the temperature in the room dropped. Dr. Hartman's expression was ice. Your patient? Clara's eyes went to the gurney and recognition flickered across her face. Sergeant Webb. Hey, Clara? Marcus managed a weak smile. Clara set down the blanket and moved to his side. She didn't look at the monitors. She looked at Marcus. Tell me what happened. 3 rounds. Mosul. Bad. Ambush. Clara's hands were already moving, not to equipment, to Marcus himself. She felt the pulse points at his neck, his wrists. Her fingers pressed gently against his abdomen in specific locations. She watched how he breathed. She touched the skin around his wounds, feeling temperature differences. Clara, we have all his vitals right here, Taylor said, pointing to the monitors. Heart rate, BP, oxygen sat. I can see that, Clara said quietly. She pulled out her traditional stethoscope. Dr. Hartman couldn't help herself. We have acoustic monitoring. This works fine, Clara said. She listened to Marcus's chest, then his abdomen, then his chest again from a different angle. 30 seconds of silence while Clara listened. Then she straightened up. The chest tube can wait 10 minutes. The shoulder wound is manageable.
But the abdominal wound, there's active bleeding. I can hear fluid accumulation, probable liver involvement, but the angle suggests it might have caught the hepatic artery branch. He needs surgery now, but the approach has to be specific. Dr. Hartman stared. How can you possibly know? Because I've felt this presentation before. The pulse pattern, the abdominal rigidity in this specific quadrant, the breathing compensation, the skin temperature gradient. I've seen it 20 times. Dr. Chen stepped closer, examining Marcus. Let me check. He did his own assessment with modern equipment. 2 minutes later, he looked up. She's right, everything she said. The ultrasound confirms hepatic artery branch involvement. Dr. Hartman's jaw tightened. Lucky guess. Not luck, Clara said.
Assessment. You can't possibly diagnose internal bleeding location from just touching someone and using a stethoscope. That's not how modern medicine works. Marcus spoke up, his voice clearer now that he knew Clara was there. Worked in Kandahar. What? Dr. Chen explained. 4 years ago, Sergeant Webb was there when Clara saved 3 soldiers during a mass casualty event. Equipment was failing. She diagnosed and triaged using manual assessment techniques. Everyone she assessed survived. Taylor Morrison looked skeptical. Okay, but we have working equipment now. We don't need to do things the old way when we have better tools. The tools don't replace understanding, Clara said. They enhance it. But if you can't read a patient's body, the tools only tell you what's happening. They don't tell you why or what's coming next. That's ridiculous, Dr. Hartman said. Marcus coughed. I'll make you a deal, Doc. You're in no position to make deals. Clara assesses me. Your team uses equipment. See who's more accurate. If she's wrong, you can ban her. Outdated methods forever. If she's right, you give them the respect they deserve. The trauma bay went silent. Dr. Hartman looked at Clara, then at Marcus, then at the monitoring equipment surrounding them. Her pride wouldn't let her back down. Fine, but when your vitals crash because you wasted time with outdated techniques instead of getting to surgery, that's on you. Deal, Marcus said. Clara just nodded. She'd been underestimated before. Clara pulled her leather pouch from her pocket. She took out her notepad and pen.
I'm going to do a complete manual assessment, she said. Sergeant Webb, I need you to tell me when something hurts and how much, scale of 1 to 10. Roger that. Taylor Morrison stood by with the digital monitors, ready to compare. Dr. Hartman crossed her arms, watching. Clara started at Marcus's head and worked down, systematically, methodically. Pupils, she said, shining her penlight. Equal and reactive, but slightly sluggish. Indicates blood loss compensation, body prioritizing core functions. She checked his neck pulse points, multiple locations. She counted, timing it with her pocket watch. Pulse is 142 but irregular. There's a pattern. Every fourth beat is weaker. Suggests the heart is struggling to maintain pressure because of volume loss,
But also, possibly, because of pain interference with the vagal response. The monitor says 140 and regular, Taylor said. The monitor averages, Clara replied. It smooths out the irregularities, but those irregularities tell you what's actually happening. She moved to his chest, listening with her stethoscope. She listened for a full minute, moving the stethoscope to different locations. Decreased breath sounds on the left, as expected with the pneumothorax. But there's also some crackling in the right lower lobe, probably aspiration of blood. He'll need respiratory therapy post-op to prevent pneumonia. Dr. Chen checked with the acoustic monitor. She's right. There is crackling there. I missed it on first listen. Clara continued to his abdomen. This was the critical assessment. She palpated carefully.
Watching Marcus's face for pain responses, but also feeling for resistance, swelling temperature changes. The entry wound is here, left upper quadrant, but the bullet travelled. I can feel the track. It's angled upward and posterior. The liver involvement is on the left lobe, but... She pressed very gently in a specific spot. Marcus winced. There, that's where the hepatic artery branch is damaged. The blood is pooling here, creating pressure. That's why his BP is dropping steadily instead of crashing all at once. It's a slow leak, not a full rupture. She listened with her stethoscope over his abdomen. I can hear the fluid accumulation, the characteristic swishing sound. About 500 milliliters so far, accumulating at roughly 50 milliliters every 3 minutes, based on the sound change since I started the exam. Dr. Hartman looked at the ultrasound tech. Confirm that. The tech ran the scan. Approximately 480 milliliters of fluid in the abdomen. Blood, presumably. Clara moved to the shoulder wound. Clean through and through, as Dr. Hartman had noted. But Clara's assessment went deeper. The bullet trajectory went through the muscle belly, avoiding the brachial plexus. No nerve damage, but there's muscle tissue destruction that's going to cause compartment syndrome if we don't address it within the next 6 hours. She felt his arm carefully, checking circulation, motor function, sensation. Can you move your fingers? Marcus tried. Managed it, but with difficulty. Reduced grip strength on that side, about 40% of normal, but that's expected given the trauma and blood loss. The real concern is post-op swelling. The fascial compartment is going to tighten. He'll need a fasciotomy during the surgery, or he'll lose function permanently. Dr. Hartman nodded to Dr. Chen. Add fasciotomy to the surgical plan. Taylor Morrison was looking at her monitors, then at Clara, then back at her monitors. The confusion on her face was obvious. I don't understand, she said. How are you getting information that our monitors aren't showing? Clara straightened up, making notes in her pad. Your monitors are showing you numbers. Heart rate, blood pressure, oxygen saturation. Those numbers are important, but they're just data points. She tapped her notepad. What I'm reading is patterns. The human body tells a story when it's injured. The pulse pattern tells me how the heart is compensating. The breathing tells me about pain levels and lung function. And the skin temperature tells me about circulation and shock progression. The sounds inside tell me what's happening that you can't see. But we have equipment for all that, Taylor insisted. You have equipment that measures those things individually, Clara said. But you have to know which measurements matter, when they matter, and how they interact. A textbook will tell you what tachycardia means. Experience will tell you what this patient's specific tachycardia pattern means right now in this context, Dr. Chen spoke up. She's right. Medical school taught me to read monitors, but my residency taught me that monitors can lie or lag. Clara's saying that direct assessment gives you real-time information that's often more accurate because it's contextual. Thank you, Dr. Chen, Clara said. She turned to Marcus. How's your pain level right now? 7, Marcus said, or maybe 8. Where's it worst? Abdomen. Burning. Clara nodded. That burning sensation confirms the liver involvement. The liver itself doesn't have pain receptors, but the capsule around it does. When it's bleeding and swelling, you get that specific burning pain. She checked her pocket watch, then took his pulse again. BP is going to drop more in about 2 minutes. His compensation is failing. We're at the edge of decompensated shock. He needs to be in OR within 10 minutes. Dr. Hartman checked the BP monitor. It read 78/48. 2 minutes later, it dropped to 72/45. Taylor Morrison's eyes went wide. How did you know it would drop? Taylor asked. Pulse pattern, Clara said. The irregular beat I mentioned earlier was getting more pronounced.
That means the heart's compensation mechanism is exhausted. When that happens, BP drops. It's predictable if you know what to watch for. Dr. Hartman was no longer looking skeptical. She was looking interested. What else can you predict? Clara hesitated. This was where her methods would either be vindicated or ridiculed. If we don't get him to surgery in the next 8 minutes, his body will start shutting down non-essential systems. You'll see his extremities get cold and pale as blood shunts to his core. His mental status will decline. He'll get confused, maybe combative. His urine output will drop to nothing as his kidneys prioritize survival over filtration. That's basic shock progression, Dr. Hartman said. We know that. Yes, but I can tell you it's starting right now. Feel his hands. Dr. Hartman touched Marcus's hands.
They were noticeably cooler than they had been 10 minutes ago. The shock progression is accelerating, Clara said, based on his presentation, age, fitness level, and the specific injury pattern. He has maybe 90 minutes before irreversible organ damage begins, but the surgery will take at least 2 hours, which means we need to buy time. How? Dr. Chen asked. Clara was already moving. 2 units of O-negative blood. Start them now. We can't wait for the type and cross. Warm blankets to prevent hypothermia. That'll slow the clotting. Position him slightly left side down to put pressure on the liver and slow the bleeding. And give him a small dose of ketamine for pain instead of opioids. Opioids will drop his BP further, but ketamine will maintain his pressure while managing pain. Dr. Hartman started giving orders, and the team moved fast. Anything else? Dr. Chen asked Clara. Yes. When you open him up, go in from a left subcostal approach instead of a midline. The bullet track angles upward and posterior. A midline incision will make it harder to access the hepatic artery branch. Left subcostal gives you direct access and better visualization. Dr. Chen nodded slowly. That's actually brilliant. It's just experience, Clara said. While they prepped Marcus for transfer to OR, Taylor Morrison stood back, watching Clara work. Everything Clara had predicted was happening. The cooling extremities, the BP drop, the progression of shock, all of it exactly as she'd described. Taylor had been a nurse for 2 years. She was good with the equipment, She could run codes, manage monitors, document everything perfectly. But watching Clara work was like watching someone speak a language Taylor didn't know. Clara wasn't just treating symptoms, she was reading the whole picture, seeing things before they showed up on monitors. When had Taylor ever actually touched a patient for assessment? She realized with some shame that she couldn't remember the last time. Why would she? The monitors told her everything, except they didn't. Not really. "Clara?" Taylor said quietly. Clara looked up from adjusting Marcus's blankets. How do you learn to do what you're doing?" Clara's expression softened. "Time, patience, paying attention. I've treated thousands of wounded soldiers over 40 years. You start to see patterns. You start to understand what the body does, how it compensates."
Ours, how it fails. But we have technology now that can... Technology is wonderful, Clara interrupted gently. I'm not against it. But technology should support your judgment, not replace it. You should be able to walk into a room, look at a patient, and have a solid idea what's wrong before you ever check a monitor. How do I learn that? Practice. Next shift, try this. Before you check the monitor, assess your patient manually. Take a pulse, feel their skin, listen to their breathing, look at their color, make a prediction, then check the monitor and see if you were right. Do that 100 times and you'll start to understand. Dr. Hartman had been listening. She stepped closer. "I owe you an apology, Clara." Clara looked surprised. "Ma'am? I've been dismissing your methods as outdated, but what I'm seeing, you're not outdated."
You're foundational. You're doing what we should all be doing, using technology to enhance clinical judgment, not replace it. I appreciate that, Dr. Hartman. I want you to do a training session for the staff. Show them what you showed us today, not to replace their monitor skills, but to supplement them. Clara nodded. "I'd be happy to." Marcus, still conscious and listening, managed to smile. "Told you? She's the best." "Yeah, you did," Dr. Hartman said. "Okay, let's get you to surgery." They were rolling Marcus toward OR when his monitor alarms started screaming. "BP crashing, 60/40. "He's bleeding out," Taylor shouted. Clara was there instantly. Her hands went to Marcus's abdomen. She palpated quickly. The bleed accelerated, something shifted. Probably a clot that was partially blocking the vessel just dislodged. "We need to get him to OR now," Dr. Hartman said. "We won't make it," Clara said. Her voice was calm but urgent. "He'll code before we get there. We need to slow this bleed right now." "How?" Clara pressed down on Marcus's abdomen in a very specific spot. Firm pressure, precise location. Manual compression of the hepatic artery against the spine. It's an old technique. If I can compress the vessel, I can slow the bleeding enough to buy us 5 minutes. "That's a terrible idea," Taylor said. "You can't just press on someone's artery." "I've done it before," Clara said. "Kandahar, 2018, Staff Sergeant Rodriguez, same presentation. I compressed his celiac artery during transport to surgery. Bought enough time." Dr. Chen checked his monitors. "Her compression is working. BP is stabilizing at 65/42. Still critical, but not crashing." "I can hold this for maybe 10 minutes, Clara said, "but my hands will fatigue. We need to move fast." Dr. Hartman made a decision. "OR team, we're doing this en route. Prep the hallway OR, it's closer. Dr. Chen, scrub while we move. We're operating in 5 minutes. They ran. Clara held her compression the entire time, her hands firm against Marcus's abdomen, her face focused. She wasn't looking at monitors. She was feeling for the pulse of the hepatic artery, maintaining exactly the right pressure to slow the bleeding without completely cutting off all blood flow to the liver. Marcus was fading. His eyes were closing. "Stay with me, Sergeant," Clara said. "You're not done yet." You didn't survive Mosul to die in a hospital hallway.
Keep fighting. Marcus's eyes opened. Yes, ma'am. That's right. Just a few more minutes. We're almost there. Taylor Morrison was running alongside the gurney, maintaining the IV lines, and she couldn't stop watching Clara's hands. Steady, precise, doing what no monitor could do, directly intervening to save a life. They reached the hallway OR. Dr. Chen was scrubbed and ready. On 3, Dr. Hartman said. Transfer him to the table. Clara held her compression until Marcus was positioned. Then Dr. Chen's hands replaced hers. I've got it, he said. Clara stepped back, her hands cramping from the sustained pressure. But Marcus's BP held steady. Dr. Hartman made an unexpected decision. Clara, scrub in. Clara blinked. Ma'am, I'm not a surgical nurse. I work post-op and trauma. I know, but you know this case better than anyone. I want you in there as an observer and consultant. Dr. Chen, you good with that? Dr. Chen was already making the first incision. More than good. Clara, I want your eyes on this. If you see something we're missing, speak up. Clara scrubbed quickly and entered the OR. The surgery began exactly as Clara had predicted. Left subcostal incision, direct approach to the upper abdomen. Dr. Chen worked carefully, dissecting through layers. Okay, I'm seeing the liver now. There's the capsule tear. Clara was right, left lobe involvement, but... He paused, examining the wound carefully. The angle is tricky. The bullet tracked upward and... Yeah, there it is. Hepatic artery branch involvement, just like she said. Another surgeon on the team, Dr. Patel, leaned in. That's impressive assessment for a bedside exam. Clara watched from her position.
I'm not speaking unless needed. This was Dr. Chen's surgery, but her trained eyes tracked everything. The bleeding source, the surrounding tissue damage, the way the organs had shifted from the trauma. Clamp, Dr. Chen said. He isolated the damaged vessel section. Got it. Okay, this is stable for now. Let's assess the full damage. They worked methodically. The shoulder wound was addressed by Dr. Patel. Fasciotomy performed exactly as Clara had recommended. The chest tube was placed by the trauma team. Everything was proceeding smoothly. Too smoothly. Clara frowned. Something felt wrong. She couldn't articulate it yet, but her instincts, honed over 40 years, were screaming at her. She watched Marcus's vitals on the monitor, stable, blood pressure holding, heart rate steady. But something was wrong. Dr. Chen, Clara said quietly. Well, yes? Can you check his lower abdomen, below the liver? Dr. Chen looked up from his work. Why? The injury is up here. I know, but when I did my assessment, I felt something. A firmness that didn't match the injury pattern. I thought it was just muscle guarding from pain, but what? I want to be wrong, but please check. Dr. Chen nodded to Dr. Patel. Take over here for a moment. He moved his hands lower in the abdomen, palpating the organs. His expression changed. There's something here. Feels like... Damn. What is it? Dr. Hartman asked. Dr. Chen carefully dissected deeper. There's a second injury. The bullet must have fragmented or ricocheted internally. There's a piece of shrapnel embedded in the pancreas. The OR went quiet. That wasn't on any of our imaging, Dr. Patel said. Because it's small, Clara said. Okay, maybe 3 to 4 millimeters. Small enough to miss on initial scans, especially with all the other damage drawing attention, but big enough to cause serious problems. Dr. Chen examined it carefully. If we'd closed him up without finding this, it would have caused delayed hemorrhage, probably would have bled out post-op. Clara, how did you know? I didn't know, Clara admitted, But when I palpated his lower abdomen during initial assessment, there was a subtle firmness that bothered me. It didn't fit the wound track. The body was already starting to react to that foreign object, laying down inflammatory response, sending extra blood flow to the area. It created a texture difference I could feel. You felt a texture difference through his abdominal wall, Dr. Hartman said slowly. From a 3mm piece of shrapnel. The body tells you everything if you listen, Clara said. I've palpated thousands of abdomens. You develop a sensitivity to what normal feels like. Anything different stands out. Dr. Chen carefully removed the shrapnel fragment. Got it. Let me check for any other surprises. He spent 10 more minutes doing a thorough exploration of Marcus's abdomen. No other injuries found. Okay, he said. I think that was it. Clara, anything else bothering you? Clara studied Marcus carefully. The monitors, his color, the way his body was positioned on the table, the surgical field. No, she said finally. I think we're good. Then let's close him up. As they began closing, Dr. Hartman spoke to the room. This patient would be dead right now if not for Clara's assessment. Our imaging missed that shrapnel.
Our monitors wouldn't have caught it until he started bleeding out post-op. But 40 years of hands-on experience felt something wrong. She looked at Clara. I've been wrong about your methods. They're not outdated. They're essential. We've become so dependent on technology that we've lost fundamental clinical skills. Dr. Patel nodded. In medical school, they taught us physical exam techniques, but in practice, I always go straight to the imaging or the monitors. When was the last time I actually spent 5 minutes doing a thorough manual assessment? I can't remember. That needs to change, Dr. Hartman said, starting with this department. 3 hours later, Marcus was in recovery, stable. The surgery had been successful. Dr. Hartman called a meeting in the conference room. Clara, Dr. Chen, Dr. Patel, Taylor Morrison.
And several other nurses attended. We need to talk about what happened tonight, Dr. Hartman began, because it exposed a serious gap in our clinical practice. She pulled up Marcus's case on the screen. Initial imaging showed the 3 gunshot wounds. We saw the liver damage, the pneumothorax, the shoulder injury. Our monitors gave us vitals. We had all the data we thought we needed. But we missed critical information that Clara caught through manual assessment. The irregular pulse pattern that predicted BP drop, the specific bleed rate she calculated by listening, the compartment syndrome risk she identified, and, most importantly, the pancreatic shrapnel that our imaging completely missed. Taylor Morrison raised her hand. But, to be fair, that shrapnel was tiny, even with better scans.
So we might not have caught it. That's exactly the point, Dr. Chen said. Technology has limits. Imaging has limits. But a skilled hand assessment can sometimes catch things that slip through the technological cracks. Clara spoke up. I'm not saying we should abandon technology. That would be foolish. But technology should be the second opinion, not the first. You should assess your patient with your own hands and brain first. Form a hypothesis. Then use technology to confirm or refute that hypothesis. Right now, we do it backward, Dr. Patel admitted. We look at the scans first, read the monitors, then examine the patient. We're letting technology form our hypothesis instead of using it to test our own clinical judgment. Dr. Hartman nodded, which makes us lazy, and in medicine, lazy gets people killed. So what do we do? Taylor asked. We train, Dr. Hartman said. Clara, I want you to develop a comprehensive training program for this department. Hands-on assessment techniques, how to read a patient without monitors, what to look for, how to recognize patterns, all the things you do automatically that we've lost. I'd be happy to, Clara said, and I want it mandatory. Every nurse, every resident, every attending. We're going back to basics. Some people won't like that, Dr. Patel warned. There's a lot of ego in this profession, but admitting we need to relearn fundamental skills. Then they can work somewhere else, Dr. Hartman said flatly. I almost lost a patient tonight because we were too proud to value old-school assessment techniques. That stops now. She looked around the room.
Daima medicine is both art and science. We've gotten very good at the science part, the technology, the research, the data. But we've neglected the art, the hands-on skills, the pattern recognition, the clinical intuition that comes from experience. Clara represents that art, and we're going to learn from her. The room was quiet for a moment. Then Dr. Chen started clapping. Dr. Patel joined, then Taylor. Soon the whole room was applauding. Clara felt her eyes getting wet. In 42 years, she'd never received recognition like this. She'd always been the old nurse with outdated methods. Now, finally, people understood. 1 week later, Clara started her first training session. 20 nurses and residents packed into the conference room. Some looked interested, some looked skeptical. A few looked openly annoyed at being pulled from their regular duties. Clara stood at the front, calm and prepared. Good morning. I know some of you don't want to be here. You think what I'm going to teach you is old-fashioned or unnecessary. I respect that, but give me 2 hours, and if you still think manual assessment skills are useless, you're free to leave and never come back. She gestured to the hospital bed in the room, where a volunteer patient, a recovering trauma patient who'd agreed to help with teaching, was lying. This is James. He came in 3 days ago with abdominal pain. He was diagnosed with appendicitis, had surgery, and is recovering well. What I'm going to show you is how I would have assessed him without any equipment. Clara approached James. First rule, look before you touch. What do you see? The group stared. He's lying down, one nurse offered. More specific. How is he positioned? Where are his hands? What's his breathing pattern? What's his colour? They started looking more carefully. He's slightly curled on his right side, Taylor Morrison said. His hands are near his abdomen. Good. That position tells you he's protecting his abdomen. Pain localization. His breathing is shallow. Watch his chest. He's avoiding deep breaths because they hurt. And his colour? Slightly pale, another nurse said. Yes, not dangerously pale, but paler than healthy. Indicates some degree of stress on his system. Now, before I even touch him, I already know. Abdominal pain, likely right-sided based on his positioning. Significant enough to affect breathing. That narrows my differential diagnosis considerably. Clara continued the demonstration.
Are you showing them how to palpate abdomen in the correct sequence, how to listen for bowel sounds and what they mean, how to check for peritoneal signs? This is what we call a systematic assessment, head to toe, every time, no shortcuts. You do this enough times and you'll develop an intuition for what's normal and what's not. Not everyone was convinced. Dr. Marcus Tillman, a senior resident, spoke up. This is all very impressive, Clara, but in a real emergency, we don't have time for 10-minute manual exams. We need answers fast. That's what monitors are for. Clara nodded. Fair point. So let's do an experiment. She gestured to another volunteer, a nurse, who'd agreed to simulate an emergency presentation. Sarah here is going to pretend she's in distress. Dr. Tillman, I want you to assess her using only equipment and monitors. You guys, I'll assess her manually. We'll see who gets accurate information faster. Dr. Tillman looked confident. Okay. Sarah began acting, clutching her chest, breathing rapidly, looking panicked. Dr. Tillman immediately started hooking up monitors. Pulse, OX, BP cuff, EKG leads. Clara just walked up to Sarah and put her hand on Sarah's wrist. 15 seconds later, Clara spoke. Panic attack. Not cardiac. Respiratory rate is elevated but regular. Pulse is fast but strong. No diaphoresis. No actual distress breathing. She's hyperventilating, but her oxygen exchange is fine. Color is good. This is anxiety, not a medical emergency. Dr. Tillman was still waiting for his BP cuff to finish cycling. The monitor beeped. BP 145/95, heart rate 132, O2 sat 98%. So, hypertension and tachycardia, Dr. Tillman said. Could be cardiac. It's not, Clara said. Watch her breathing pattern. It's too regular for true respiratory distress. And feel her pulse. She guided his hand to Sarah's wrist. Strong pulse. Regular. Fast, yes, but not weak or thready. If this was cardiac, you'd feel changes in pulse quality, not just rate. Dr. Tillman felt it. His expression changed. Oh, your monitors told you numbers, Clara said, but they didn't tell you the story. I got the diagnosis in 15 seconds because I looked at the whole picture. You got partial information in 45 seconds and would have needed more tests to reach the same conclusion. Point taken, Dr. Tillman admitted. Sarah stopped acting and sat up, smiling. That was fun. The room was quiet. Even the skeptics were paying attention now. One more thing, Clara said. Doctor, Tillman isn't wrong that we need to move fast in emergencies, but fast doesn't mean skipping assessment. It means your assessment becomes automatic, instinctive. You can do everything I just did in literally 15 seconds once you've practiced it enough. That's faster than waiting for a monitor to boot up. Clara's training sessions became legendary at Walter Reed. Word spread through the hospital. Nurses started requesting to attend. Residents who'd initially scoffed came back for second sessions. Even some attendings showed up, quietly sitting in the back to learn. Marcus Webb, now recovering in his room, heard about it. He asked to see Clara. I hear you're teaching the whole hospital how to be old school, he said, grinning. Clara smiled.
Apparently refusing treatment from everyone but me had some consequences. Good consequences. How are you feeling? Like I got shot 3 times but alive, thanks to you. Clara checked his vitals the old-fashioned way. Pulse, breathing, color assessment. Then she checked the monitors. They matched her assessment, as always. Your recovery is ahead of schedule, she noted. You'll be out of here in another week. Then what? Then you go back to your team, I assume? Marcus was quiet for a moment. Clara, I've been thinking. I'm retiring from active duty, medical discharge. They offered me a position at Fort Bragg, training new Delta operators, medical survival skills, what to do when things go bad. That sounds perfect for you. I want you to help me design the curriculum. Clara looked surprised. Me? You saved my life twice.
Hey, once in Kandahar, once here. Both times in situations where modern equipment failed or wasn't available. I want to teach those guys what you know, how to assess casualties in the field, how to make medical decisions without technology, how to keep someone alive with basic supplies. Clara considered this. I'd have to clear it with Walter Reed. Dr. Hartman already approved it. I asked her yesterday. She said you could consult part-time, develop training materials, even come down to Bragg for live training exercises. You've been busy. I don't waste time. So what do you say? Clara looked at this young soldier who'd trusted her when nobody else would, who'd literally bet his life on her skills, who'd forced an entire hospital to reconsider what they thought they knew about medicine. Yes, she said. I'll do it. Marcus grinned.
What outstanding. 2 weeks later, everything Clara had taught was put to the ultimate test. A commercial aircraft crashed during landing at Reagan National Airport. Over 200 passengers, mass casualties. Walter Reed's ER was about to be overwhelmed. Dr. Hartman stood in the trauma bay, coordinating response. We're expecting 30 critical patients in the next hour. Every available hand on deck. Clara was scheduled for a post-op shift, but she came down immediately. Where do you need me? Triage, Dr. Hartman said. We need rapid assessment. Sort the critical from the urgent from the stable. The first ambulances arrived. Chaos poured through the doors. Burned patients, trauma patients, smoke inhalation, broken bones, internal injuries, all arriving simultaneously. The monitoring equipment couldn't keep up. Not enough monitors for everyone, not enough time to hook everyone up. This was where Clara's training became crucial. She moved through the incoming patients rapidly, 15 seconds per patient, hands-on assessment, quick, decisive triage. Critical, internal injuries, get him to trauma bay 1. Urgent, smoke inhalation, needs oxygen and observation, but stable for now. Minor, broken arm, stable vitals, send to orthopedics when available. Patient after patient. Clara's hands moved automatically. Pulse check, breathing assessment, skin color, pain response, mental status. Taylor Morrison worked beside her, trying to use the same techniques Clara had taught. I've got a patient with decreased breath sounds on the left, Taylor said. Tachypneic, using accessory muscles. Pulse is weak and fast. Tension, pneumothorax? Clara asked. I think so. Tracheal deviation? Taylor checked. Yes, slightly to the right. Good catch. Get a chest tube tray. Do a needle decompression now if an attending isn't available. Taylor hesitated. I've never done one outside simulation. You know how. The patient can't wait. I'll supervise. Taylor grabbed the supplies. Clara talked her through it. 30 seconds later, the needle was in. Air hissed out. The patient's breathing immediately improved. You just saved his life, Clara said. Now get that chest tube in. Around them, the training was paying off. Nurses who'd learned Clara's techniques were making rapid assessments, catching problems early, stabilizing patients before they crashed. Dr. Chen was in surgery with the first critical patients. Dr. Patel was managing the trauma bay. Dr. Hartman coordinated everything. Ud and Clara kept triaging. 40 patients in 90 minutes. Then the hard one came in, a young girl, maybe 10 years old. Her mother was screaming following the gurney. Clara did her rapid assessment. Multiple injuries, burns on her left side, obvious broken leg, but worse. Her abdomen was rigid. Her pulse was weak and rapid. Her breathing was shallow. Internal bleeding, severe. But Clara felt something else, something that made her blood run cold. She palpated the child's abdomen carefully. There, a firmness, a mass that shouldn't be there. She'd felt this presentation once before, 20 years ago, Afghanistan, a child with shrapnel wounds. This wasn't just trauma. This child had an abdominal aortic injury, the main vessel that fed blood to her lower body. If it ruptured completely, she'd die in seconds. But right now, it was just barely holding, a partial tear, blood leaking slowly, the body trying desperately to compensate. Clara had maybe 5 minutes to get her to surgery. Dr. Hartman! Clara's voice cut through the chaos. Dr. Hartman rushed over. What? This child has an abdominal aortic injury, partial tear. She needs vascular surgery immediately or she'll die. Dr. Hartman checked the monitors. BP was low, but not critical. How can you tell? I can feel the mass, the way her abdomen is pulsating in this specific area, the pulse pattern in her femoral arteries, they're weak and delayed. Classic presentation. We don't have imaging. There's no time for imaging. We need a vascular surgeon now. Dr. Hartman made the call. She trusted Clara. Get Dr. Rodriguez from Vascular, emergency OR. I tell them we have a pediatric abdominal aortic injury. They rushed the child to OR. Clara maintained manual pressure on the child's abdomen during transport, trying to slow any bleeding, trying to keep that partial tear from becoming a complete rupture. The mother ran alongside, crying, "Is she going to be okay?" Clara looked at her. She wanted to say yes, but she'd never lied to her family. "We're doing everything we can. She's got the best team possible." They reached OR. Dr. Rodriguez was there, scrubbed and ready. "Clara says abdominal aortic injury," Dr. Hartman said. "No imaging to confirm." Dr. Rodriguez looked at Clara. "You sure?" Clara met his eyes. "I'm sure." "Then let's move." Clara stepped back as they took the child into surgery. Now it was just waiting. If Clara was right, they'd save this child's life. If she was wrong, that she'd sent a child into emergency surgery for an injury that didn't exist. Everything she'd taught, everything she'd fought for, everything she'd proven. It all came down to this moment. Clara sat in the hallway outside OR waiting. Taylor Morrison sat beside her. "You did the right thing." "I hope so." "You saved 30 patients tonight with your assessment skills. That little girl is number 31. Or she's the one I got wrong." They sat in silence. An hour passed. Then Dr. Rodriguez emerged from OR. He pulled down his mask. His expression was unreadable. Clara stood up. "Well?" "You were right," Dr. Rodriguez said. "Partial tear of the abdominal aorta, exactly where you said it would be. Another 10 minutes and it would have ruptured completely. She wouldn't have survived." Clara's knees went weak. Taylor caught her arm.
How did you know?" Dr. Rodriguez asked. "Even with imaging, we sometimes miss those." "I felt it," Clara said simply. "The pulsation pattern, the mass consistency. I felt it before." "Well, whatever you felt, you saved that child's life. She's stable. Prognosis is good." Clara closed her eyes. "Thank God." Dr. Rodriguez looked at Taylor. "You learning from her?" "Every day," Taylor said. "Good. Because what she has can't be taught in medical school. It only comes from experience and attention." He looked back at Clara. "Thank you for being here, for knowing what you know, for teaching it to others." He went back into OR to finish closing. Clara sat back down, suddenly exhausted. Taylor sat beside her. "You know what you are." "What?" "You're not outdated, you're timeless. There's a difference." The hospital held a ceremony.
Clara hadn't wanted one, but Dr. Hartman insisted. "This is important," she'd said. "People need to see this." So Clara stood in front of the entire medical staff, nurses, residents, attendings, administrators, while Dr. Hartman spoke. 1 month ago, this hospital was forced to confront an uncomfortable truth. We'd become so dependent on technology that we'd lost fundamental clinical skills, skills that save lives when technology fails, skills that catch problems technology misses. She gestured to Clara. Nurse Clara Patterson reminded us that medicine is both art and science. She showed us that 40 years of experience, 4 decades of hands-on patient care, creates a kind of knowledge that no monitor can replace. Since then, Clara has trained over 200 staff members. Her assessment techniques have caught problems that imaging missed. Her triage methods saved lives during the airport disaster. Her willingness to teach has fundamentally changed how we practice medicine in this facility. Dr. Hartman held up a plaque. "On behalf of Walter Reed Medical Center, we present Clara Patterson with the Excellence in Nursing Award, and we formally establish the Patterson Protocol, a mandatory training program in hands-on assessment techniques for all clinical staff." The room erupted in applause. Clara accepted the plaque, her hands shaking slightly. "Thank you," she said, "but I didn't do this for recognition. I did it because patients deserve the best care possible, and sometimes the best care means slowing down, putting your hands on your patient and really paying attention. Technology is wonderful, but it should serve medicine, not define it. We should use every tool available, both the new and the old, because at the end of the day, It's not about being modern or traditional. It's about being thorough. More applause. Later that day, Clara returned to her floor, back to her regular patients, back to her work. A new nurse, fresh out of school, first week on the job, approached her nervously. "Ms. Patterson?" "Yes?" "I'm Nurse Kelly Andrews. I just started, and I wanted to ask if you'd mentor me." Clara smiled. "Of course." "What do you want to learn?" "Everything. I'm good with the equipment, but I don't know how to really see patients, not like you do." "Then let's start now. Come with me." They walked to a patient's room, an older man recovering from surgery. "Before we check his chart, before we look at his monitors, I want you to assess him. What do you see?" Kelly looked uncertain. Then she really looked. "He's breathing kind of shallow. His color looks okay. He's holding his side." "Good. What does that tell you?" "Pain, maybe from the surgery?" "Let's check. Go take his pulse manually." Kelly did. "It's fast, maybe 100. Now check the monitor." The monitor read 98. "Close," Clara said. "Now ask yourself, why is his heart rate elevated? Is it pain, anxiety, infection, or something else?" They spent 10 minutes doing a complete assessment. Clara showed Kelly how to palpate the surgical site, how to listen to breathing patterns, how to check for signs of complications. "This is amazing," Kelly said. "They didn't teach us this in school." "They taught you the basics," Clara said, "but basics become skills through practice, and skills become wisdom through experience. You'll get there. Will you help me?" "Every step of the way." Clara looked at this young nurse, eager to learn, hungry for knowledge, representing the future of medicine, the old ways and the new ways, finally working together. This was how it should be.